Shreya Kangovi, and I'm on the faculty of the Division of General Internal Medicine. I want to thank you for having me here and giving me this opportunity to speak. I'm going to try to quickly paint a picture of the last 4 years of work that have recently culminated in the creation of the Penn Center for Community Health Workers, and I hope this can be useful as a case study of action research. I'll start by the problem description by way of this map here. So we know that health systems are increasingly accountable for patient outcomes, outcomes such as not only hospital readmission, but chronic disease prevalence, HCAHPS scores for quality of care, primary care access, etc. We also know that there are high-risk populations, typically low-income geographic communities, that are at risk for having poor outcomes across the board in each of these domains. And so when we began this work, we started actually by engaging individuals who were members of this high-risk population, these high-risk communities, in order to understand from their perspective what was causing these poor outcomes and what they thought ought to be done differently. And we did this by using qualitative participatory action research. PAR is a type of research methodology in which researchers collaborate with stakeholders who themselves are affected by a problem in order to generate not only knowledge of the problem, but potential solutions. And so when we did this, we essentially did qualitative studies with about 120 of these individuals, and we cataloged using qualitative analytics the barriers that they faced and use that in this design mapping process in order to translate into the design of an intervention. So this is just one row of an example of this design mapping, but we would catalog the barriers that patients were telling us that they faced. For example, patients really valued, they felt a disconnect from traditional healthcare personnel. They felt that they weren't being heard and they wanted to not be judged by the typical doctors, nurses, social workers. And so we then mapped each of those barriers to a step of an intervention that might address that barrier. So a community health worker might conduct an open-ended, strengths-based interview. We then took that intervention step and asked ourselves, well, what traits and skills would a workforce member need to have in order to perform that intervention step? So, for example, the community health worker would need to be non-judgmental, and we heard from patients that they thought that the person should listen more than they talked. And finally, we said, what skills would they need to have? And we thought it would be useful for them to be trained in motivational interviewing. And this, of course, is one row in a catalog that was about 5 pages long, but we took that and ultimately used that to create our intervention. This column became our intervention protocol. The traits column became human resource guidelines for how we actually identified and selected community health workers. And the traits column, the skills column became the basis for our training. So moving forward, this led to the design of a community health worker intervention called Impact or Individualized Management Towards Patient-Centered Targets. This model relies on community health workers and is really grounded in goal-setting theory, helping patients to deconstruct long-term health goals into proximal goals that are achievable and meaningful, and really kind of is rooted in behavioral economic theory, because the achievement of these smaller, proximal, meaningful goals is actually the reward that then potentially could stimulate further health behavior change. And so community health workers are lay people who share life experience with their patients and who are natural helpers within the community. As Roy alluded to, this is not a new workforce, but historically what we found doing literature review and expert interviews is that many community health worker programs had been ineffective or unsustainable. And we isolated 5 reasons that we thought contributed to this limitation. One was organizations had difficulty knowing how to recruit the right community health worker, and this is a people-based intervention, as Thomas Bodenheimer said. It's only as good as the people that are delivering it. So recruitment guidelines and best practices were required. There needed to be clear work practice in order to avoid turnover and variability in performance. These programs needed to be integrated into healthcare delivery systems in terms of workflow and financing. There were often a lot of disease-specific programs that were not able to scale. And then finally, a lot of these programs existed without the support of high-quality scientific evidence, according to the HRQ systematic review. So when we were designing this model, we not only designed it with the design mapping for the needs of the high-risk patients in mind, but also to address these limitations. So we ultimately, after designing the model, did test it in a randomized controlled trial that was published recently in JAMA Internal Medicine, and this was a trial of hospitalized patients who were low income and who were also uninsured or Medicaid, had a variety of health conditions, and we found that a 2-week dose of the intervention significantly improved a range of outcomes really across the triple aim, which is what we were intending to do. The differences in each domain are fairly modest, but what we often find in healthcare interventions is that you move one aspect of the triple aim at the expense of others. So I think one thing that we were interested in is that we were able to actually increase access and not see a cost in an uptake in utilization, which you often find in other studies. And there were also some modest improvements in actual health outcomes as well. So, of course, this is where we often stop with the publication of a scientific manuscript, and it's very difficult, as Roy also alluded to translate this into actual practice. So, we were funded actually by the University of Pennsylvania Health System to create the Center for Community Health Workers, the mission of which is to integrate evidence-based CHW models into routine healthcare delivery. And so we're really excited to collaborate with other institutions to work on continuing to innovate this model. And I just want to close by acknowledging a lot of people who contributed to this work, most importantly Judith Long and David Grandy and Roy Rosen. Thank you.